pathway. So welcome everybody. I've got with me today Ed Seaward, and so Ed is a consultant gastroenterologist at UCH and has helped us all the way along with FIT and has led the introduction of FIT into UCH and its related hospitals. So let me pass over to Ed, who's going to take us through the first set of slides, and then I'll talking about the data and the studies that underpin the use of FIT, and then I'll talk in more detail together with Ed about using FIT in the less than 10 pathway. Thanks. Welcome, Ed.
Thanks very much, Claire. James, are your slides up? I can't see them at the moment.
Yes, they are showing.
If you just, if you just move on to the second slide. Yeah, we've got those up then, Ed. We can see them, though we can't see you actually, so it's a camera. I think we could see you before.
Oh, yeah, no, my camera's on. Hang on.
Do you want me to give a little bit of introduction while you come on and go off, so we can see
weirdly, I can actually see the slides on my phone.
Okay.
So let me have a go, and if you don't lose anything by not seeing me, trust me. So for those of you who don't know, FIT testing, it stands for fecal immunochemical testing, and basically it's a specific antibody against the globin portion of hemoglobin, and that makes it much more sensitive than FOB testing that was directed against the heme portion. FOB testing was qualitative, so you had to get somebody to look at it to try and document a color change, whereas with FIT, I'm sure everyone on the call is aware, you get a number, and how low or high you make that number will vary the sensitivity and specificity of the test. And really the most important thing is that it's way more sensitive than symptoms are. Next slide, please, James.
That's come up. Can you see that, Ed?
I've got that one now, yeah. So this is actually a relatively old study where they looked at a whole bunch of things that might predict the presence of colorectal cancer, and essentially FIT, with the exception of finding a hard craggy mass when you PR'd somebody, FIT was the best way of anticipating the presence of cancer. It outperformed any other symptom, or indeed the presence of anemia. Next slide, please. And for those of you who are into statistics, you'll know that, so the red line is the performance of FIT, and the more sort of right angle the curve makes, the more accurate it is, and the closer to the y equals x line, the less accurate it is. And symptoms is represented by the blue line. So basically symptoms are really rubbish, whereas FIT is really good, is all this slide shows. And obviously we know that from the fact that in NCL, the cancer conversion rate for the two-weight colorectal pathway was about 2.5%. So only 2.5% of our patients actually had bowel cancer, despite there being a clinical suspicion of that. Next page, please. Next slide, please. So we do have local data. So this was a study that Claire and I were involved with, and we took about 4,000 patients on the two-week weight pathway, mostly from NCL, but not exclusively. And I know it's a really complex slide, so I've drawn out 3 major points I would say are the take-homes. First one is that it is a really sensitive tool for picking up bowel cancer. So in our study, if you had a negative FIT, or the correct terminology nowadays is you're meant to say a FIT below threshold. So if your FIT was below threshold, so your threshold being 10, you had a 99.5% chance of not having bowel cancer. And actually the QFIT study that we were involved with is probably at the low end of the usefulness of fit, and there are studies suggesting it's even higher. So if your fit is below threshold, you can be fairly confident that individual does not have cancer. The other thing is that, from my point of view as endoscopy lead at UCLH, where I'm trying to do less symptomatic colonoscopy if I can get away with it, nearly 80%, 78.5% of patients on the 2-week weight pathway were fit. The fit was below threshold, the fit was negative. And of course, that's really good. So, I mean, potentially we could turn away almost 80% of our patients, so we wouldn't have to scope them, at least on an urgent basis. And then the final point was, if you look at the positive predictive value, I've already told you that based on symptoms, it's 2.5%, and that increases fourfold to nearly 10%, so 9.7% of patients you would detect with fit who'd have cancer. So it's a really good tool for sort of enriching the population and who you're going to concentrate your resources on. And that's really important when you're considering the current capacity constraints within the NHS, as you can imagine. Next slide, please. Okay, so that was data that went into the QFIT study. This is data from our region by secondary care sites, so the Royal Free, Whittington, unfortunately North Mid can contribute data, and UCLH, and by all means peruse those figures. But essentially the key points I got out from this was that about 1 in 6 referrals, so 16% of our referrals, were actually fit less than 10. So these could have been hived off from a 2-week weight pathway. So, okay, you're seeing the guy in your practice, you're doing a fit test is negative. Okay, you still have clinical suspicion, which means you're sending them up, that's fine, but we could do that on a non-urgent pathway, and that's affecting 1 in 6 referrals. Nearly half the referrals didn't have a fit test done, and I appreciate probably better than most the difficulties of trying to persuade patients to have poo tests done. So I do understand there are complex reasons for this. And if you look at it another way, if you look at it at colonoscopies performed, I mean, that data is going to pretty much mirror the fit data. But again, from my point of view, 17% of the colonoscopies carried out as part of the 2-week weight program were done on a fit less than 10, and about 40% had no fit score. And so from my point of view, when I'm trying to, particularly when I'm trying to age extend bowel cancer screening, as you know, we've gone from 60 to 56, and we're hoping to bring it down to 50. As I'm trying to age extend and increase.
Ed, I think we might have lost you.
Can you still hear me? Sorry, my computer.
Now, just now. Yeah, we lost you when you started saying age extend. You were talking about age extension and the fit test result helping with that.
Sorry, if we have a look at the national data, next slide, please. You'll see that it's a very similar picture. And I don't think where we are necessarily stands out in NCL. We're all fairly similar, with the possible exception of the Midlands, and I'll probably talk about them in a second. But I think what it tells us is it's not just us that has to do a lot of work in terms of improving our fit compliance, but really it's everyone. And we are still investigating lots of patients who have a fit below threshold. I should say that one of the reasons the Midlands are so good is that they've probably got the best English experience of using fit, so they're quite well honed with that. And their data is really interesting. And what they found is that using fit doesn't decrease the number of patients sent in on a 2-week wait referral, but what it does do is it greatly increases the numbers of patients with cancer that they're detecting on the 2-week wait pathway. And most importantly, they're diagnosing earlier cancers because there's less of a wait for those patients who are at high risk due to their FIT. And I think that's really we should keep our eyes on the prize here. That's really the sort of holy grail of colorectal cancer management, is if we can either diagnose people in the precancerous stage, and that's where screening comes in terms of picking up the polyps. But if they are seeing you guys in clinic with their rectal bleeding or whatever, they're having FIT tests which allow them to be appropriately triaged to an urgent pathway, and therefore we're picking up their cancer at an earlier, more treatable stage. Next slide, please.
So that was taking me onto the second part, Ed, but I just wondered if anyone's got any questions at the moment, or if you just wanted from that previous slide, which some people might have had sort of difficulties focusing on the detail of, Ed, whether you just wanted to talk about numerically, if you're able, so that they're obviously in the Midlands then seeing a rise in their conversion rate, are there? Because a high proportion are patients with a positive diagnosis, because they're using FIT in that way.
Yeah, so what I can't do is probably give you figures off the top of my head, I'm afraid, but what their data tells them is that if you're using FIT in an entirely rational way and you've got good compliance, and you probably saw from that national data, only 11% of their patients were being sent up without a FIT compared to 42 in NCL and elsewhere, then what they were able to demonstrate was a much better conversion rate in terms of detecting bowel cancer. And it's slightly contentious, but what their data suggests is that they are probably seeing a stage shift in colorectal cancer. So they're diagnosing people at a younger age, at an earlier stage, which is phenomenal to me.
Yeah. How long do you think that their data collection will need to run to get a more reliant confirmation of that quantitatively, do you think?
Oh gosh, it all depends on their numbers, doesn't it? I mean, one advantage of the Nottingham data is that they have a natural comparator, in that they have an independent treatment centre which is not using FIT for triage. It's just accepting 2-week wait patients on the traditional symptoms-based criteria, and they were able to demonstrate theirs was hugely superior to theirs in terms of number of patients needed to scope before you diagnose a cancer. So I would expect, and of course this is a big advantage now that we're collecting data nationally, is one would hope that we're able to demonstrate some significant changes in terms of our detection rates and stage of detection, because we'll just have so much more data. Yeah, absolutely. Thanks. But remember,
sorry, go on.
Sorry. Yeah, I mean, just to say, they've been going with FIT since about 2016, so they've got a few years on us. But what they've done is shown us the direction we need to travel.
Yeah. Great. Got a question from Jennifer Ray from Islington. Jennifer, do you want to speak your question, or do you want me to read it from the chat?
No, I'm happy to ask it. I mean, I think from conversations locally, I think a lot of GPs do get a bit confused about what to do when a patient comes with a history of rectal bleeding. And I think there can be a bit of confusion as to whether you proceed to do a Q-FIT, and actually practically giving a patient instructions about trying not to do the test when they actually see blood in the stool is quite complicated. So if you wouldn't mind taking a little bit of time to explain that, I think people would probably be find that helpful.
That's a really question. So, slightly counterintuitively, FIT testing works in patients with PR bleeding, and you would think it wouldn't, but it does. And the reason is, if you have a hemorrhoidal bleed, so you have your poo in your toilet pan with a bit of blood dolloped on it, and your patient catches the bloody poo and dunks the FIT. It's called a picker, is the sort of plastic thing that you sample the poo with. If you dump the picker inside the blood, then of course it's going to come back as being positive. So what you have to counsel your patients, and I do this as well in clinic, you'll all be delighted to hear that I use FIT as well, and I don't just colonoscope everyone. I say, look, if there is blood there, either do your sample on another poo, or just make sure you sample. If they say, oh gosh, there's blood every time, then you sample away from the blood, because the idea is, obviously, if you're bleeding from a more proximal lesion and it's drip, 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 and it's going throughout the stool, then sampling away from the bright red sort of anorectal hemorrhoidal bleeding will still allow the FIT to be valid. And that came through the data in the QFIT study, and that's been also replicated elsewhere, that you can use FIT testing even in the presence of PR bleeding, but you just have to tell the patients to either sample a non-bloody stool or sample away from the blood. And generally, I find if I explain that to people, it kind of makes sense. Does that seem reasonable, Jennifer?
No, I think that's really helpful and clear. And I think there is definitely misunderstanding about that. So I think people will find it helpful. So thank you.
Good. And we can always re-mention it again. We'll try and put something into, we'll either put it into one of the Joe's webinars when I join that, or another way to contact people, just to remind them of that. And there probably are people on the call who've been doing that for some time. Nitika, I can see you on the call. I guess you've been asking patients to do that if they have been bleeding. Would that be right? Yeah.
Yes.
And you haven't had a problem with that?
No, I think as Ed just said, it's about the explanation.
There's quite a lot of transmission noise. If people could stay off mic if they're not speaking. Sorry, Nitika, off you go. They're not speaking. Sorry, Nitika, off you go. They're not speaking. Sorry, Nitika, off you go. They're not speaking. Sorry, Nitika, off you go.
Have we still got an echo?
It's clear now, Nick, so go ahead.
No, I was just going to say, I think as Ed has said, it's all about the explanation. And I think as we're beginning to see more and more patients face to face, doing that explanation has become a lot easier than trying to explain it down the line and having to sort of send leaflets and explanations that can get misconstrued.
So best to do it at the time, Nitika, yeah? And it gives us the opportunity. We know there's lots of data around in GP endorsement and how effective a motivator that is for patients. So I guess it's always really helpful to spend a minute when you're speaking to the patient about announcing that you want to do a FIT test, to just explain in detail what that is. And the other thing, the couple of things I think to remind people is that they mustn't get the sample picker contaminated with toilet water, and so that usually and that they should do the test within 30 minutes of producing the poo. If you speak to the chemist, biochemist, they'll tell you that the FIT test starts to degrade immediately that you produce the poo. Significant degradation doesn't happen until after 30 minutes, and so if you're doing it, and most people tend to do it in some container, it's important to remind them not to put it on the side and then forget it, but to do the test within the first 30 minutes. Elizabeth, you posted also in the chat. So you're happy with the answer we've given about whether you should do fit tests with hemorrhoids and how to do that test? Because I think essentially, are you saying, can I just clarify, Elizabeth, are you saying you want to know if someone thinks they've got piles, you should also do a fit test? Is that what you were thinking, or how to do it in relation to bleeding? Okay, so you said that's brilliant. You've been asking that question for ages. So just to clarify, if you want to do a fit test from a clinical perspective, you don't put the picker in the poo, you need to avoid it. But separately, just because someone has got piles, you're always allowed to have more than one pathology at the same time. So if you've got concerns that you think they've got other bowel pathology because of how they describe their symptoms, or because of an anemia that's developing or anything else, then it's worth doing the test. And I think, Ed, can I bring you in here? Thank you.
Thanks. I love the idea that somebody would put a poo sample aside for more than half an hour. I think if anyone's pooing in an ice cream, well, really? But the point I wanted to make about if we're talking about when to use fit is just to stress that it's when you think there could be cancer there. So, arguably, if they have NG12 compliant symptoms, we get a not insignificant number of patients on a 2-week wait who might have, say, a fit of 120 and a calprotectin of 7,000, and surprise, surprise, they have inflammatory bowel disease, or they're just like young patients when you're not really thinking about cancer. And the problem is these guys get stuck on a 2-week wait, and then you can imagine we're scurrying around trying to get them sorted. And that's particularly true now that we've got colon capsule as an option, because there's a bit of a run up to colon capsule, which is slightly more fiddly than doing a colonoscopy. But we figure that that's probably the best test to do in young patients. So please do fit tests if you think there could be cancer there, but not if you don't think. 99% of bowel cancer occurs in the over 45s, and I know it is increasing in younger patients, but it's increasing from not very much to still not very much. So please do bear that in mind. Thanks.
Thanks. And Ed, can I draw your attention? Jennifer's popped another clarification question in the chat around how long would you accept a negative fit test before repeating it if not referred on the less than 10 pathway?
Okay.
So how long would you, before you think there's a problem?
Yeah, so Jennifer, you're definitely getting the best question awards today. And that's a really hard question to answer, actually. It's similarly, when I'm trying to work out how long the colonoscopy keeps you safe for, so when you should repeat it. And I think these are all unknowables. What I would say is there is a false negative rate for fit, surprise, surprise, like there is in any medical test. So what we're saying, we're going to come on to this, is that we would repeat, if we were safety netting our patients, we would suggest a repeat fit in 6 to 8 weeks if that patient still has symptoms that aren't explainable by any other mechanism. So that's probably what I would say to you, but that is utterly unevidence-based. There is some evidence saying that if you repeat very quickly, like within a week or so, that does not contribute towards usefulness of fit. So I wouldn't do it, immediately. I would give it a bit of time, and waiting a month or two is not going to make a massive impact on colorectal cancer staging if the worst came to the worst and the first fit test was a false negative. So I would suggest waiting. I would suggest what we're doing, what we're proposing, which is 6 to 8 weeks. But basically, nobody knows the answer to that, Jennifer. So tough question. Thank you.
But I guess it's all about, you kind of, it may be that you need to see the patient again, Jennifer, re-examine them, repeat other blood profiles. So it may be, I think don't ever be worried about going through that cycle again. If you're not sure with a patient, sometimes other things develop, and seeing them face to face and having a hand on their tummy quite often will lead you to a point in your diagnostic pathway where you come down one side and the other or the other. So I think nobody, there is no negative, no reason for reassessment. If you feel unsure, then it's best to reassess. Is there anything else that people would like to ask about what we've heard so far? I've got one question actually from Nitika, which I'm going to ask you to speak, Nitika, actually, about when doing fit testing in relation to the national DARES and IIF.
Sure. So
try now.
The current guidelines state for GPs that the fit has to be done within 7 days of referral before or 14 days of referral after. I was just wondering, is there any evidence base around this? Because it just seems to be piling on more pressure onto primary care.
Do you think they were just trying to think of a way to say, please do a fit when you refer? Nitika?
I mean,
and
obviously,
that's all they were aiming for when they used that
with
language.
the figures that we, Ed's presented, yes, that might have been one of the options. But I just feel that, put a week before a referral, sometimes the patient's gone away, sometimes, and then now we're having to repeat tests to ensure that we, comply with the guidance and get the referral done.
Yes. Yeah. Jennifer, can I bring you in?
So one of the things that we've sort of discussed in Islington has been the possibility of asking centrally whether an alert could be put on the 2-week wait forms. Because I think, as with everything, our computer system, EMIS, allows us to receive alerts at various stages when you're using referral forms. And I think more broadly, if you wanted a sort of more belt and braces approach, as well as educating GPs, I think that would be a really helpful sort of aid memoir whenever we're actually completing the forms, with a little box that comes up to say, have you done a or have you considered doing a Q-fit test? And then maybe referring people back to the guidance around it. Because I think if you really want to change habits, then I imagine that would be a harder hitting and you would reach more people by doing it.
Yeah. So I agree about the dialogue around the timing of the fit test in relation to the DARES and ILF. And what I'll do is Cancer Alliance CDs meet the national lead for cancer, who is the person who's driven this introduction of the use of fit into the national DARES. So we'll raise it formally and see if they can amend that wording, because it's clearly not is counter, not helpful always, depending on how people's diaries and the patient's diaries are moving, as Nitika and Jennifer have explained, and also Elizabeth's comment around locum. So I think that'd be entirely sensible. I think all they were trying to do was encourage people to have a fit test sent with a result. So I think the really important thing is to remove the 7 days before, rather than the 7 days before is the important thing, probably. Jennifer, did you want to say something else? You've got your hand up still.
No, sorry, that's historic.
Okay. So I agree. So I will I think it has been something that's been reflected before, but we'll kind of re-escalate that and see if we can get some traction. Sometimes it's extremely difficult changing the party line at national level, but it would be sensible if we could. So we'll try again. Okay, any other questions on that before we move on to the next bit? And actually you can, we don't, Ed and I are quite happy to field any questions at any time, aren't we, Ed? Even if it doesn't fall into the slide that we've got on the screen at the moment. So let's just move to the second bit, which was around the Fit Less Than 10 pathway and why we're doing it. And in fact, the first slide is just a summary of the tests that we use to investigate people when we are concerned about colorectal cancer. Ed, I wanted to ask you if you'd give us a couple of minutes on colon capsule, actually, just for people who aren't really sure how that happens, where it could happen, whether or not the thing can get posted to the patient.
You're really pandering me.
Well, why not? Sure.
So colon capsule, really interesting piece of tech, and basically it's a little camera pill that you swallow. It's about the size of a large vitamin pill, and obviously the big advantage to that is that it gets around the idea that you have to have a tube up your bottom. And if you look at the bowel cancer screening program, it's got about a 2/3 sort of compliance rate, and so there's a third of patients out there we're not reaching, and obviously one of the reasons could well be that people don't like the idea of a tube up their bum, and so colon capsule gets around that, and the data on it is still emerging. There's a big study done in Scotland which is due to report this year. I mean, it has initially reported, but we're getting more data through. And there's also NHS England have done a big project on it. So there's going to be tons of data on colon capsule. But the way it currently stands is it's probably as good as a colonoscopy in terms of picking up cancer and significant polyps, which is, I guess, all we need to know. The disadvantages for it is, whereas when I do a colonoscopy on somebody, I stick the tube in and I can wash and suck poo out, so I can manage a bit of poor prep. It has to be spotless for a colon capsule because it's obviously can't do any of that. So that's one thing about colon capsule. And the second thing, which is probably the most relevant to what we're talking about today, is obviously it's only diagnostic. So it can't, if it sees a polyp or it sees a cancer, it can't sample it or chop it off. So it is a perfect test to do where you think a patient has a low risk chance of having polyps or cancer. And of course, with FIT, we have the perfect triage tool, because that will tell us, one thing we've not talked about FIT is that the higher the number, the greater your chance of having pathology. So if your FIT is 11, then your risk of having bowel cancer is probably about, 1.5%. It's still pretty low, to be honest. A FIT of 40, your risk is about 3%. A FIT of 80, your risk of having cancer is about 20%. It gets quite high. So what we're doing at UCLH is that if your FIT is 40 or less and you're reasonably young and fit, because more elderly comorbid patients can't cope with the bowel prep for colon capsule, then we're offering them colon capsule on the 2-week wait service. The idea being that hopefully we'll be able to do colon capsule on them and reassure them that they don't have cancer, and then they can go about their business happy. Now, the really exciting thing we're doing at UCLH is that we're actually doing the service at home. So we send them out a box with the capsule and the prep, and we do a video call to do so they understand how to set the capsule up and then swallow it. And that's great for patients because they can sit in their front room having a non-invasive test which rules out bowel cancer, which is really great. And nobody's done that before, so that's quite exciting. So all those, arguably inappropriate 2-week wait referrals that get sent in with patients with positive FITs, but they're 28 and they've got a FIT of 15, those are the ones I'm going to be doing colon capsule on. And it's a very powerful tool. And we're still evaluating it at the moment, but we've got data on about 100 patients and the data looks great. People are very happy with it. So thank you for indulging me, Claire.
No, that's fine. So just to say that as we move forward, we'll be hoping that that the capsule become more and more readily available closer to home, but actually it doesn't really matter because you can post it. So but in terms of wherever people are referred in our sector, as you continue to collect your data around colon capsule, more and more people over time will be able to have access to it if they fulfill the criteria, won't they, Ed, as we go forward? Yeah. So yeah, I think we'll see more and more of that as time goes on. Right, I think let's go to the next. One question, I think, before we can leave that slide up if you like, James, but I've just caught sight of Jennifer's question. How does colon capsule compare to CT examination?
Yeah. So it's probably so there's one head-to-head study which suggests it's better than CT, but admittedly that test was done with like really bad CT and interpretation. So certainly the radiologists at UCLH said if they were missing so many polyps on their CTCs, they'd be in trouble. So there's one head-to-head study which says it's better. It's probably equivalent, would be my interpretation of the data. Yeah,
right. And I guess through all of this, the thing we only refer to in passing, but actually is essential, is how carefully people prepare their bowel. And Ed referenced that when he was talking about actually using the capsule. I think it's really helpful if we as GPs remind people there's a proper preparation procedure. It's going to be clearly described in what they'll receive in the post, and they can't cheat. A lot of them think, oh, well, I'm just going out to dinner tonight, so I will anyway, and then I'll start my, then I'll start this. It's the preparation a bit late, but it'll be okay, and it won't be okay actually. So it's really important to tell people they need to follow it exactly as it arrives. As soon as they get it in the post, and they should follow the instructions completely. And sometimes on people I know who find it difficult to follow that kind of instruction, I sometimes sit down and talk to them about the advantage of trying to clear their bowel a little bit in preparation for the actual prep. So to try and have a couple of days beforehand of lots of clear soups and not much else, and then I'll either try and link it to their pre-Christmas diet they're planning, or their pre-beach diet they're planning, or whatever it is. And but whatever hook you need to use, I think it's worth spending a very short amount of time on that, just to really convince people and help them understand that it's essential. And without doing it properly, the test will often be compromised. So thanks. So going on to the next bit of the study, next bit of our presentation, I just wanted to talk a bit more about Fit Less Than 10 so that everyone's clear about it. This is our sort of phase 3 of what we're doing, and we're doing it as a 1-year service evaluation, so that the experience of managing a patient with a Fit Less Than 10, where you have referred them, is going to be all the safety netting and all the assessment is happening in secondary care just for a year, so that we can control exactly the intervention that's being given, so that we're able to analyse the results very carefully. And then after we've got to that point, it may be that we revert to what people are doing in other parts of the country, which is managing it within primary care. So this is a 1-year service evaluation, and it's really helpful that I think most people, I've had really good feedback, even from GPs, that also are really glad that this is going on, so that we can trial our safety netting and look at its effectiveness in this kind of service evaluation environment. If we could go, I think probably just go straight to slide 13, James. Just to remind, next slide. Yeah, so this is just a reminder to people, and we have talked about this before, but it was to look at this in detail. So you've got NG12 patients described in the sort of red boxes, and DG30 patients described in the green. If you look at it quickly, you might think the things are the same, but actually they are different in relation to ages, when the if people get symptoms, or the actual precise level of anemia, and the age related to that is quite important. But essentially, if patients fulfill the criteria in the red box, then they're NG12 patients and will need to be referred straight in. If you do a fit test and they have a fit less than 10, then please just use our fit less than 10 pathway. As you can see, we've got a summary in the white writing there. So NG12 and fit more than 10, referring to the 2-week wait pathway. NG12 symptoms, fit less than 10 with no rectal mass, then please refer into that special pathway. Okay, has anyone got any questions they want to ask about that? We have had questions in the past, because sometimes people feel it's not clear, but we've tried to split it like this to make it clear. And there are some important comments that are sort of useful clinical bits in black print at the very bottom around the descriptions of iron deficiency anemia. In the same way, before we leave this slide, for GPs, I know that, I mean, I certainly have, and I'm sure you'd have, an awful lot of patients where our assessment of their perceived risk is really minimal, and they, in fact, after we've assessed them, they fit the criteria in the green box. Then they don't need to be referred on to the fit less than 10 pathway. They need to stay with us, and provided we have got no other concerns, then you can end the sort of episode, but make it clear to them that if they have further symptoms or further concerns, then they need to come to you again. And this is probably the time that's right in the presentation, just for me to emphasize that we still find from patient groups that lots of patients are confusing what it means to have a normal fit screening test. So with the normal fit screening test that uses a cutoff of 120 rather than the 10 as a cutoff that we're using here for referral because of investigating symptoms, it's really important that if a patient says to you, well, if you're considering that they're in the, let's say they are in the originally in the green box, but something else happens, they come to you and they say, well, actually, I wasn't really sure about mentioning this at all because I've had screening and the screening test was negative. I think if they've got some other new symptom or you found an iron deficiency anemia which fits with the criteria of NG12, so that essentially shifting across, you need to send them on, and don't sort of remind them that if you have bowel symptoms, just because you have a normal screening, it doesn't mean there's nothing wrong with you, because the cutoff is so very different. Yes, Michael, thank you. No, I don't. I would say it probably doesn't. Each laboratory is slightly different. Ed, do you have a view? Can you see Michael's question? Royal Free Hampstead define lower limit of haemoglobin for men at 13.5 grams per litre, yeah. 135 grams per litre, not 130.
I mean, I personally think NICE missed a trick by trying to laboriously define anemia. Anemia to me is whatever is below, the lab threshold that you use. So if at the Royal Free, it's a hemoglobin of 134 is anemia, then fine, refer it. It's anemia is just whatever is out with the the parameters as defined by your local lab, in my opinion. I hope that's not too controversial, Claire.
Yeah, no, that's fine. And I think in general practice, the other thing I'd say is, as a clinician, sometimes nothing follows the absolute guidelines. But if you trend people's haemoglobin on an individual basis, although they might ostensibly be within a normal range, they may be following a positive or negative trend. And I think that's clinically then a significant observation. Would you agree, Ed? Do you see what I mean? Sorry, we can't hear you, but you're nodding.
Yeah, no, 100%. I agree with that entirely. And there's plenty of data for that. And indeed, there are computer algorithms, aren't there, that can track minute changes in hemoglobin that, you know, would otherwise be missed. And similarly, you know, it's a reason for checking platelets, isn't it? You know, we all know that platelets go up in the presence of cancer. So it's, you know, there are lots of subtleties within a full blood count that you can pick out. Yeah.
Thanks. So next slide. Thanks, James. And this is a summary slide that's a narrative as opposed to pictures, but just it's a reiteration just to helping people be clear. So DG30 symptoms, if their fit is less than 10, then you're going to look after them in primary care. If their fit is more than 10, even though you originally thought they were a DG30 patient, that bumps them up to the 2-week wait pathway. So that's what you need to do with them. In patients with clear NG12 symptoms, then if you've got on examination the rectal mass, the anal ulceration that NICE has spoken of, then you refer immediately and you don't need to wait for a fit. That doesn't mean you don't have to do it, but you should refer immediately. So these might be the people that would fall into that 14-day afterwards descriptor that Nitika raised early on. Refer immediately, don't hold the referral for the level, but still do the fits. And the reason for that is it's really useful for comparison, for management over time, and also it helps with when people are collecting data. In any other NG12, if you've got any other NG12 symptoms, if the fit is more than 10, you're going to refer on that 2-week wait pathway. If the fit is less than 10, then you refer to our specialist pathway. You happy with that, Ed? Yeah. And this yellow bit here is just to draw people's attention to the RDC, the Rapid Diagnostic Centres. We've got 3 of those, one at UCH, one at the Royal Free and one at the North Mid. Patients can go to any of those 3. How patients are managed is very similar in all of the 3 hospitals, and so often it's a kind of public transport decision that encourages people to choose one or the other. It doesn't matter, but essentially it's really important that it's helpful if you do a fit and include it in the referral. And usually the nature of these patients are they've been in primary care a little bit of time, so there's usually has been time to do a fit, but it is from our perspective really helpful. And I see patients also in one of our RDCs, and I can certainly say from kind of real life experience, it's really helpful to me if I've got that fit on the referral. So, and then there are some things that we've mentioned before that are sort of soft clinical things like looking for negatively trending bloods. And if you're not sure, complete the kit and it just read through, as we've said. So more than 10 2-week wait pathway, less than 10 non-specific RDC pathway. If you're really not sure what the primary cancer might be, because if during your assessment of the patient it becomes very clear that they're satisfying the markers for colorectal cancer, so they've got a fit more than 10, then even though you might have initially thought you'd refer them to the RDC, in fact you need to switch and refer them to the 2-week wait lower GI pathway. Thanks. Next slide, please. Okay, so this is for people, just as a reminder, where you'll find the leaflet if you want to print it off during the consultation. When you go into TQuest, and if you press info, it will launch this little box here with a web link, so that that's to keep the always ensure that the what we're printing out is up to date. So there'll always be the most up to date local NCL version there on this web link. Any questions about that? Can't see anybody waving. Okay, and next slide, please. Thank you. This is what this is a kind of 20. This is not for reading the small print. It's just for you to recognise what it looks like. So the referral form for fit less than 10 looks. It says slightly different from a 2-week wait form, so they can't be confused, but not so different that your brain doesn't sort of link them together, and you will therefore, we've made the decision that we keep it in the cancer folder in EMIS, so that's where you'll find it if you're trying to find it. We had a long discussion about that, but it seemed the most obvious. And if you're looking, let's go to the next slide, James. If you're looking to for numbers that you want to, or summaries that you want to use to remind patients, I think the 99.5% chance of not having colorectal cancer if you've got a fit less than 10 is a good one. It always remains possible, as we've said, if you've got any other query and you're in the middle of and things don't quite make sense, but for whatever reason you haven't made a referral on, then I suspect we'll see repeat fits, as we've discussed already today. More and more people will do repeat fits, but they're not mandatory. Okay, and you can remember you can send these referrals to everybody, any of our trusts in NCL. If you go to the next slide, I've given a summary. So this is just a pictorial view of what we've said before, but it might be the easiest bit to look at afterwards to bring everything together. And let's just talk a little bit about how we're going to measure our data that we're collecting. So we're asking all the trusts to collect the same data. They're working to very tight protocols, aren't they, Ed? You've got just a few staff in each trust doing this, so there's we're minimising the risk of people being inadvertently managed in a different way or inadvertently safety netted in a different way. We're looking at preliminary audit data as we go through the months of this year. It's really, really important, therefore, for you to do fit whenever a patient is coming to you with symptoms that make you feel that you want to exclude or investigate further colorectal pathology, so that we up our numbers of tests. And it's also really helpful if you delay the referral until you can till you've got the test, so that you know which bit of the pathway you're going to send people on to. Essentially, you should only be referring to a 2-week wait pathway without the fit test if you found a mass, as we discussed at the beginning. If you haven't found a mass, there's absolutely no evidence anywhere internationally that you will cause a problem to a patient by delaying if they're not in acute obstruction and you can't find a mass. Would you agree, Ed, as the specialist here today? You're happy that the few days it takes to get the fit result back is not going to lead to any detrimental effect in a patient? Yeah.
100%. And as we've discussed, if you take a global view of it and more patients are sent in with fits, that will actually allow us to concentrate on the high risk populations. So everyone benefits.
Yeah, thank you. Thanks. Okay. So, and we think what we're going to see from this, we hope, we think that our successful evaluation will give us more information to understand the appropriateness of referrals on the 2-week wait pathway. And we're pretty sure from data in other areas that Ed's already talked about, that where you're very good with including your fit test results. So in the Midlands, where they're getting only 11% of referrals don't have fit, then they're certainly seeing an improvement in the appropriateness of referrals, and they might be seeing a stage shift in diagnosis. We'll probably have to wait a bit longer, but that's quite fundamental. And the really important thing, I think, for us in primary care, and for me, is because I'm also a GP, is that we are therefore looking very carefully at the question of where it's most appropriate for patients to be safety netted. And that's why we really felt very strongly that we wanted to do this for a year first before we decided ultimately where would be the best place, primary or secondary care, for people to be safety netted. And we'll come to the data should be able to give us a very clear decision after that. I think I've come to the end really of the presentation. There's just one slide at the end you may want to put up, which is just around some of the documents that you can find. You can source them on the website. You can source them through especially the link that I showed you when you're ordering the test. If you've got questions, James, who's been doing all the sharing of the slides, works with Ed and myself, and if he's happy to receive any contact, and then he'll make sure we get the queries. And there's a couple of questions that I think we've got 3 minutes for two things. Ed, do you want to can you see those questions? I'm not sure if you can see them. Do you want to take whichever one you want to first?
Okay, so I guess starting with Heather's at the bottom. So please can you discuss what secondary care follow-up happens for patients referred up on the fit less than 10 pathway to have review in clinic or telephone review or repeat fit? So it's going to be a face-to-face assessment by a senior decision-making colorectal surgeon. So in other words, a senior reg or consultant. Is going to be face-to-face, so basically so they can stick a finger up their bottom and reassure them, that they've got hemorrhoids or whatever. And then one of the reasons we wanted to do this is I suspect that a lot of these patients may well end up being investigated anyway, because we're all doctors and it's hard not to investigate people with symptoms. So they might need a CT for their abdominal pain or whatever. That will be communicated to you. And then I think, was there a similar, Elizabeth, I accept your point entirely about continuity of patient care. We're quite unusual doing the safety netting in secondary care. The reason we did that really was just to try and concentrate the patients so that we could collect the data and ensure that everyone got a very similar experience. I would anticipate once this study has been complete, I suspect that we're going to we might end up returning these patients to primary care. So then you will get your continuity of care, but obviously careful what you wish for. Claire, did you want to do any of the others?
I think, yeah. So I think it was Jennifer. Just Jennifer's question. Yeah. Do feedback from secondary care for GPs who are completing 2-week waits or QFIT less than 10 referrals that would make the pathway smaller? So are we doing anything wrong apart from trying to make sure you've always got the fit test actually on the referral form? I mean, theoretically, it should suck it up and put it into the form, but it'd be really helpful to check. And I'll take on board that comment that somebody gave us right at the beginning. I think it was you, Jennifer, actually, about whether we could actually introduce a flag just before you send the referral off, which sort of says, hey, have you included the fit on the form? Is there anything else, Ed? Yeah.
Yeah, I think so. My point would just be about young patients, particularly, and I understand why this happens, is you got a patient you suspect has got IBD, they're quite symptomatic, and they get sent up on a 2-week wait service so they can get sorted quickly. If you could, really, we should be offering urgent access IBD, suspected IBD clinic slots anyway. Please let me know, particularly if you're in the UCLH catchment zone, advice and guidance, or email me directly. James, we can circulate email addresses because I want to know about those. I would like to carve those patients away from the 2-week wait process. And if we need a formal sort of way of doing that, I'm very happy to do that. If you've got young patients that you're worried about, keep them away from the cancer pathway, please. That's really important.
Because they're much more likely to have inflammatory bowel disease, is what you're saying.
Yeah.
Okay. Yeah, no, absolutely. Okay, I think we've kind of come to 2 o'clock. If there are questions that we haven't had time to cover yet, that we can't yet see in the chat, please just pop them in now, because then when we will go through all the questions again, and if there are extra ones, then we'll produce a set of answers. Yeah, thanks, Ed, for your email, and that will get to you directly. Anything else that people want to say, please just wave or yell. Otherwise, I think we'd say thanks very much, Ed, for joining us today. Always helpful to understand all the stats and the evidence behind something. So that's really helpful. It's been really good talking to all of you. And please let me know, or otherwise separately, most of you got my email, claire.stevens@nhs.net, if anything else comes to mind. Thank you very much for attending. See you all soon.
Thanks
I hope
for
one way or
listening.
another. Yeah, thanks.
Thanks.
Yeah. Okay, thank you. Bye-bye.